Hello friends, I'm Dr. Rajesh Chokhani, a general pediatrician from Bandra, Mumbai, and today we will be talking about early clinical diagnosis of malignancy. So friends, childhood malignancies may be difficult to detect early because if there are any associated symptoms, they may not be specific and in fact they may mimic other more common disorders. The same phenomenon may apply to adults as well, with a small difference being that after a certain age in adults, we anyway consider malignancy as a differential, whatever be the symptomatology. In fact, screening is recommended for malignancies in adults for this reason, which we will talk about later. And malignancy can also occur in a newborn, so no age is exempt. Therefore, for early clinical diagnosis of a malignancy, we need to cross-examine or carefully evaluate every common presenting symptom and have a high index of suspicion. Now, as we said, these presenting symptoms, when they present in isolation, they more commonly represent other common pathologies. So, when faced with such symptoms, we are always going to think of those other common pathologies first. But then we have to notice or pick up a different or a special character or attribute to those symptoms which will alert us, or when they occur in particular combinations which are dangerous, that will alert us, and that is how we may suspect a malignancy early. So let's look at fever. Fever would usually suggest an infection, but when the illness does not follow the usual course of any infection, when the fever does not localize, when it does not respond to the commonly started antibiotics, when over a period of time the condition of the patient remains the same, that is neither worse nor better, in spite of the fever continuing over a few days, it would suggest that this is a non-infective fever, and from there on malignancy becomes one possibility. Leukemias, lymphomas and neuroblastomas may present this way. At times, the patient may run a very low-grade fever which is due to tissue destruction, which may be seen in chronic inflammatory conditions as well as malignancies. In both these fever situations, we may be additionally alerted by some accompanying constitutional symptoms or combination symptoms which we will see shortly. Progressive pallor is something which, when it happens over a short duration, it has to be always viewed suspiciously. This is because deficiency anemia usually does not happen over a short duration, unless of course if it is related to blood loss. So we can always, by history and examination, look for corroborative markers of overt or occult blood loss, like history suggestive of worms, hard stools, menorrhagia, etc., or hemolysis like icterus, and in the absence of either of these, we must consider malignancy as a possibility. In fact, a short duration fever with severe anemia is a hallmark of a hematological malignancy, and then if the illness is progressing very rapidly, it could be a non-Hodgkin's lymphoma. If it's associated with hepatosplenomegaly, it could be a leukemia. If it's in a young infant without obvious localization, it could be a neuroblastoma. Acute onset of petechiae would usually suggest an immune thrombocytopenia. But if the patient is sick, or if it is associated with other symptoms like fever and pallor, then it alerts us to the possibility of a malignancy like a leukemia. Weight loss is partly a function of the chronicity of the illness and partly a function of the how catabolic the illness is. In children, most of the malignancies are relatively recent onset disease processes. So weight loss in isolation is not a prominent symptom of childhood malignancies. In fact, it is seen more often in children in, say, diabetes mellitus or a chronic inflammatory condition, tuberculosis, etc. But when weight loss is not explained by any of such conditions, then of course we must look for a malignancy. As against this, in adults, weight loss is a very strong pointer to a possible underlying malignancy. A headache which is particularly more severe in the morning and which is persistent over the last few days or weeks with occasional vomiting is a suspicion of a CNS tumor even without a neurological deficit. Similarly, a focal seizure needs to be investigated early. One possibility could be a CNS tumor. Lymphadenopathy would commonly suggest infections, but then if it is a rapidly progressive lymphadenopathy which is non-tender, firm to hard, and which is at a particular site like a supraclavicular lymph node or epitrochlear lymph node, or is asymmetric, and here we also consider asymmetric enlargement of tonsils as a similar phenomenon, then it should alert us that this might be a malignancy. Generalized lymphadenopathy, of course, can be an infection, but it can also be a malignancy. A bone pain which is persistent with or without a local bony swelling may suggest a local bony malignancy. Bone pains and joint pains can also suggest leukemias. So it becomes very important to differentiate what looks like a rheumatological condition from a possible more sinister condition like a malignancy. So there are subtle pointers which we must look out for. So a pain which is more severe at night, waking up the patient at night, or a pain which does not allow the patient to bear weight on the limb, or the severity of the pain and severity of the associated systemic findings are much more in comparison to the local findings, or it is a non-articular pain, or it is a new onset painful limb, and it is not associated with morning stiffness. These are some of the features that we should look out for. Similarly, we must be clinically alert to a pathological fracture. That means we must pick up the disparity between the severity of the injury and the resultant fracture, because this tells us that the bone was abnormal at that point. Whether it's a local bony abnormality, a local bony malignancy, or a secondary from a distant malignancy like a leukemia, we will have to figure out. Mediastinal masses are usually asymptomatic, but occasionally we might see a superior mediastinal syndrome in the form of facial and neck puffiness with prominent neck veins, or we may sometimes get a hoarseness of voice due to the compression of a recurrent laryngeal nerve. An abdominal mass or lump is one of the commonest presentations of malignant solid tumors in children, and it could well be a Wilms tumor or a lymphoma. It may or may not be otherwise symptomatic. On examination, a sick look is a subtle pointer that may make the big difference in how we look at these non-specific symptoms otherwise. Similarly, if we must always look for bony tenderness and palpate all the bones, because many times a primary is hidden somewhere and secondaries are seen in the bones, and it is that then alerts us to the possibility of a malignancy. A white reflex in the eye may be the early and the only manifestation of a retinoblastoma. While talking about the eye, a sudden loss of vision or a sudden squint should make us suspicious. An incidentally detected hypertension or a opsoclonus myoclonus may be a subtle pointer to a neuroblastoma. And as we have already said, any mass or lump anywhere in the body, particularly if it is asymptomatic or minimally symptomatic, it must be evaluated for a malignancy. Sometimes we get clues on basic investigations. For example, a febrile patient with a leukopenia with marked neutropenia and relative lymphocytosis, or a significant normocytic normochromic anemia, or a bicytopenia or a pancytopenia, or a 3-digit ESR, or a persistent occult blood in urine and stool, or a mediastinal widening or a mediastinal mass on a chest X-ray, These clues should not be missed. Sometimes some individuals are predisposed to malignancies. So children with Down syndrome, ataxia telangiectasia, or certain immunodeficiencies may be predisposed. Some subjects who are treated for a malignancy are at risk of a secondary malignancy, and at times there are familial predispositions to malignancies. So all this must be kept in mind, and it will help us to pick up a malignancy earlier. In adults, the same principles follow. So any palpable breast lump must be investigated thoroughly, and it could be a malignancy, particularly if the lump is hard, adherent to the skin, causes nipple puckering or a nipple discharge, and is non-tender. Similarly, a recent change in bowel habits or passage of blood per rectum could be a sign of a colorectal cancer. Similarly, a non-healing ulcer in the mouth may be a cancerous lesion. Of course, in adults also, they may be asymptomatic till the malignancy is considerably advanced, and that is why screening is recommended in adults beyond a certain age, depending on the incidence of the malignancy as per age. So we have screening recommended for prostatic cancer, breast cancer, colorectal cancer, and even cervical cancer. So friends, in spite of the constraints that we talked about, early clinical diagnosis of malignancy is possible if we carefully pay attention to the subtle clinical pointers in history and examination. Thank you. The next video will be by Dr. Tushar Maniyar on early clinical diagnosis of inborn errors of metabolism. Thank you.